So we have section 2 here. We're going to start off talking about blood in the heart. Basically, section 2 is going to be covering mainly the cardiovascular system. We're also going to talk about the immune system a little bit later on. And then finally, we'll kind of finish up with the respiratory system towards the end there. So again, we're getting, it's very, very critical to understand a lot of this because this has become so important, especially like in CMS courses when you get to cardio, when you start talking about pulm stuff. It's really important to understand kind of the basics here, how things work normally, so that way you understand when diseases come along and kind of alter that, how you can treat those, right? How you can manage those patients there. So today we're going to be discussing mainly just cardiac function, some of the vascular regulatory systems. We'll get into more detail on the specifics as we go along. But the main thing here is just kind of cover the basics, so kind of what is making up the actual cardiovascular system for the most part. And we'll also talk about clotting cascade and all of that. You've covered the clotting cascade in Clin Lab, correct? Anywhere else have you covered it? All right, so we'll go into a little bit more detail. We'll talk about some clinical examples of how we can, have this system, how we work with it in the medical field, and get some good examples there. Anyway, so today we're talking about mainly the composition of the blood and then some of the structures of the heart. Those will be kind of the main things we're hit on among some other topics. So the functions and components of the system. Ideally, what is the cardiovascular system doing for us? Pumping blood. What does blood do for us? It delivers oxygen. Good. It also does many other things. It's going to be picking up CO2. It's going to be delivering that to various places. It's going to be carrying a lot of waste products, a lot of nutrients, things like that around the system. Yes, deliver substances around the body essentially. Mainly it's going to be composed of the heart, as you might guess. How many chambers in the heart? 4. Do people always have 4? Oh, you may find some congenital heart disease where you may actually be born with less than that, and that's usually a surgical sort of issue. You may find if you ever work with like peds cardiothoracic surgery, you'll run into that with some regularity there. Next, we have our blood vessels, which of course the heart should be connected to most of the time. You're going to have the arteries, arterioles. You're going to have the capillaries, venules, and veins. You guys are familiar with that. And then what is in those vessels? The blood. Yes, absolutely. So, and we'll talk a little bit about the lymphatic system later on. We'll cover the basics here, but we'll talk about that in lecture 4. And the lymphatic system is good for what? What does that help us with? Yeah, immunity, fighting off infections, inflammation. We're going to find that's going to be critical there. So we'll talk more about that in detail in lecture 4. But we'll cover kind of the constituent components here in this lecture today. All right, so composition of the blood. What is in the blood? Basically, you're going to find there's kind of these whole blood components. We're going to have the plasma. There's going to be maintaining, roughly 50%, a little bit more than 50% of the components there. Most of it's going to be water, as you might guess. So again, water is very important to maintain the balance of the blood. We talked about tonicity. We talked about maintaining the osmolarity. Water is a big component of that. There's also going to be some proteins here. What do proteins in the blood do for us? Yeah, so it can help to transport things. What else? Yeah, so tonicity, help with the tonicity there as well. Did someone say anything about holding water in? I heard someone say that. So we'll also talk about oncotic pressure a little bit later, but that's also a big thing. It helps to actually maintain volume within the vasculature, as we'll see in a little bit. And next we had the formed elements, which is making up roughly the other 45% or so of the blood there. And this is where we're going to have basically a lot of our cells that are comprising of the blood. So mainly going to be the red blood cells there, and then also have other things like the white blood cells and the platelets. So this is a good breakdown. So imagine here you have the actual blood itself. How you're going to break that down into the plasma, most of which is going to be water. And then looking at the proteins that are going to be making up the plasma, you're going to see things like albumin's a really big important one. The globulins are also going to be really important, as we'll see, especially for regarding things like immunity. Fibrinogen. Anyone know what fibrinogen does? Yep, helps with clotting, right? So we'll talk about that a little bit later on. And then with these other soluses where we're going to have like our sodium, our potassium, bicarbonate, glucose, all this other stuff is going to be located here in this this relatively small component of the blood. And then on the formed elements, you're going to have like your platelets, obviously, which are good for clotting. We'll see leukocytes, which are used for what? Immunity, fighting infections, things like that. And then the erythrocytes are going to be the major component there, which obviously we know does what? Red blood cells, carries. Yeah, that's going to be one of the big components we're going to see. It also helps carry CO2, as we'll see in just a little bit. But the carrying the oxygen is kind of the main concern we have, at least for the current talk. So, as I mentioned, albumin is going to be creating, it's called a colloid. And so you'll hear me talk about this again when we talk about fluids more detail. Actually, I just did this talk with the second year students yesterday. There's going to be kind of 2 terms you'll hear me talk about. I'll talk about crystalloids, I'll talk about colloids. The main difference between those colloids is usually made up of some sort of protein-based fluid. So when I said, if you're ever giving a patient albumin, that's going to be considered a colloid. And giving a crystalloid, anyone take a guess what that means? You think crystal, you think like salt, you think, usually some sort of like electrolyte-based sort of solution. So for instance, when I say normal saline, which is what percentage sodium chloride? Yeah, remember 0.9% sodium chloride, that's considered a crystalloid, right? If I had a lactated ringers, that's a crystalloid because it's made of like a salt-based solution essentially, right? So that's a crystalloid, colloids are going to be protein-based. So when you hear colloid, that's basically what I'm referring to. Albumin is maintaining this osmotic pressure. So when I say osmotic pressure, anyone take a guess what that is? Because when you're looking at things like sodium, you're looking at other ions, like those can actually flow out of the vessels, like depending on how they're being transported around. But proteins are very large. You think they have an easy time crossing those biologic membranes? They can't. They're too big to cross in a lot of cases, even if they were lipophilic. So because of that, the proteins really don't leave the blood vessels. Yes, sir, you had a question?
Just osmotic pressure.
Yeah.
Just the concentration of solids and stuff is pushing up against the vascular walls.
Yes, yeah, that's basically what we're going to be getting to, absolutely. So yeah, so those proteins, since they can't leave, they kind of provide a constant sort of osmotic pressure, which is going to be basically what's driving the water into the vessels and kind of keeping the water there essentially, right? So for instance, if I had someone who had maybe a lack of albumin, someone who's not producing very much albumin, where do you think the water would want to go? Because now the solute concentration in the bloodstream is getting less and less because the albumin's not there. It's want to leave the vessels, right? So then we're going to have water being leaving the vessels, that oncotic pressure is going down, and what do you think my blood pressure would do? It would drop, right? Because there's less pressure in the vessels. Guess what? Now my blood pressure is going down. So that's one of the things that is really important if you have a patient with low albumin stores. We like to replace that because that helps to keep those proteins right there in the blood vessels. That helps to draw water in and keep it there, so our pressure is going to be appropriate, right? That our blood pressure itself is going to be good. So one big thing, so albumin's a big component of that. We also will see albumin's really important for carrying different products around, things like bilirubin, a lot of medications are carried around on albumin, so it's a good transport protein. And then we have the globulins. You have things like alpha and beta globulins, those are good for transporting like lipids and other fat-soluble vitamins around the body. And then the gamma globulins, these are really important for our function in immunity, right? So you think about like immune globulins, you think about we'll show these a little bit later on. But you think about those antibodies, that's contained in those gamma globulins, and so that's going to be really important for immunity. If you lack those, if you have a patient who maybe had a gamma globulin deficiency, they're much more likely to develop what do you think? Probably infection, right? So again, if it's important for immunity, if I lose those products, then I'm more likely to develop infection, whether viral, whether bacterial, whatever it happens to be. So that's actually a big deal. We'll have patients come in, they'll actually be infused with gamma globulins every once in a while to make sure their immune system is going to be intact, to make sure that they have retain some immunity against different diseases. And then fibrinogen, again, we know that's going to be important for clotting because that's going to eventually turn into fibrin. Good, fibrinogen turns into fibrin, and that does what for us? To hold those clots together, remember, because clots are mainly made up of what? Fibrin and then platelets, right? So we'll go over that again when we get to it a little bit later on, but that's basically what's holding that all together. It's going to be that fibrin that gets developed from fibrinogen. Fibrinogen itself is going to be water soluble. It's going to be floating around the bloodstream because, again, your body wants to maintain hemostasis. It wants to bleed, or not really bleed when it doesn't want to. It doesn't want to clot when it doesn't need to. And so you need to make sure you keep fibrinogen in a soluble state until you really need it, until you have some injury that's occurred that requires that fibrin to be developed. But we'll talk more about that later. Okay, so again, just some of the other formed elements we're going to see here with our white blood cells. We're going to be able to break these up into our granulocytes and agranulocytes. I'll show you that in a minute here. Platelets, and then obviously our erythrocytes are very important for transporting oxygen. All right, so hematopoiesis, which is what? Creation of red blood cells, absolutely. So again, you're going to see that basically, from the fetal development on, you're going to see that red blood cell development is going to change over time. And so, for instance, when you're dealing with, say, like the embryonic yolk sac, you'll be able to find these hematopoietic stem cells that actually produce red blood cells. You'll find kind of early on in life, even places like the liver, the spleen, lymph nodes can generate some red blood cells. But we'll find that later on, especially closer towards birth, you're going to find that red blood cells typically will be primarily made where? In the bone, absolutely. So the bone is going to be the main place where you're going to see red blood cell production. So you're going to find that even after birth, you're going to find that the red blood cell production is going to be shifting as time goes on. You're going to find that certain tissues will not produce it quite so much as the patient gets older. So for instance, like the tibia, I like this graph here because it kind of shows you based on age, kind of where red blood cell production is kind of happening most frequently. So for instance, like, hopefully, I don't think anyone here is less than 20 that I know of. So no one is producing red blood cells right now in their tibia. However, some of you still producing it in your femur. So good on you guys. I'm firmly not producing any more in my femur, as it would turn out based on this graph. But yeah, so basically the vertebrae, the sternum, the ribs, you're going to see a lot of red blood cell production. Also in the ilia, you're going to see that being produced in some red blood cells too, right? So again, all bones end up producing red blood cells until about age 5, and then it starts to drop off, depending on the bones you're actually talking about. All right, so then looking at this, so again, when you have a cell that has the ability to kind of differentiate into several different types of cell lines, what do you call that? Yeah, I've heard the term pluripotent before. Basically means the cell can then, based on which kind of chemical influences, what kind of hormonal influences come along and affect it, you may see it divvy up into several different types of cell lines. So for instance, when we're dealing with this multi-potential hemopoietic stem cell, and call this a pluripotent sort of cell, you may find it will break off into something like a common myeloid progenitor, turn into a common lymphoid progenitor, and you can then see other cells will be produced from that. That's important because actually, if you're dealing with cancer ever, you can find the different types of cancers may develop depending on where the mutations are and depending on what cell lines actually start to kind of replicate sort of unchecked, essentially, right? So again, if I had something like a common lymphoid progenitor, if this were to start to become cancerous and start to kind of divide without any sort of restriction on it, you'd see that you'd have something like a lymphoid sort of leukemia versus something like a myeloid sort of leukemia, right? So again, there's different types of leukemias you can see based on where the mutations occur there. So if you deal with cancer, you might run into that. Leukemias are a very common thing we run into, especially in the pediatric realm. So we deal with this quite frequently every day. We have patients coming in getting treatment for different types of leukemias there. But you see things like, growth inducers, things like interleukin-3 might come along and help to stimulate this production of different types of hemopoietic cells. And you're going to have different differentiation inducers. I'm not going to get into detail on what all those different ones are, but just know that there are going to be different types of inducers that will say, hey, maybe we're low on platelets. Let's go ahead and increase influence of this one particular differentiator to make sure we get more platelets being produced, right? More thrombocytes being developed there. Those are all very important. Again, any of these go on, undergo any kind of aberration, you're going to find different cell lines maybe either overrepresented or underrepresented, as the case may be. All right, so you can see hemopoiesis actually developing here. So again, normally you're going to be seeing that when red blood cells are being produced, they start up this kind of pro-erythroblast, and then as they become more and more developed, you're going to find that usually immature red blood cells are going to be called reticulocytes. You can actually measure that within the blood, and that kind of gives you a sign of, okay, well, am I having a lot of high fraction of immature red blood cells being produced? That can sometimes inform me about different disease processes that are going on. But then they should be able to develop actual erythrocytes themselves. And we'll talk about how we produce those a little bit later. But note here you can have different sorts of different types of anemias that can actually happen based on different either mutations, genetic mutations that occur, or based on things like if you don't have any kind of precursor molecules to make some of these. And so have you talked about different types of anemia yet? Okay, so for instance, if you have something like sickle cell anemia, have you guys talked about that at all? So what's happening there?
Hemoglobin is like binding together and basically destroying the cell.
Yeah, so basically there's an amino acid substitution that occurs where if you're in a low oxygen state, you start to see kind of this clumping of the hemoglobin there within the cell, and that's where you see these deformations that occur. It becomes more kind of sickle shaped, right? And so we'll see there's lots of problems that develop with that. Or if you're missing certain precursors, you might develop what we call like a microcytic hypochromic anemia. Lots of different ones that are out there, and we'll talk more about some of these in detail as we go forward. But just know lots of different types. And again, they all have different pathogenesis. So how do we stimulate red blood cell production? What's the main hormone? Erythropoietin, right? And so it's very important to make sure you keep a good balance between red blood cell production to the point where you want to have enough, but you don't want to have too much around. So again, if I have too few red blood cells floating around, what does that do for me? What problems could that maybe cause? I'm not oxygenating the tissues well enough, right? Because again, that's going to be the main way we're carrying oxygen around with hemoglobin. If I don't have enough red blood cells around carrying hemoglobin, I cannot deliver oxygen effectively to the tissues. Tissue becomes hypoxic. Then what does it do? Well, so eventually it becomes necrotic, but at a certain point, we need energy to help our cells to run. And if I don't have oxygen coming along, what do my cells do for energy? Yeah, they have to go to anaerobic metabolism. They have to start producing lactate. See how the stuff kind of builds on itself a little bit, right? Don't dump all the stuff from the test just yet. But yeah, so you see that your cells will have to switch over to an anaerobic metabolism. You're going to start to develop lactate. You're going to become acidotic. You're going to see that has problems for blood pressure and all kinds of other issues. So you need to make sure you're delivering enough oxygen to the tissue. So you need enough red blood cells around for that to occur. However, what would happen if I had, say, too many red blood cells around? Okay, yes, you have polycythemia for sure, but what problems could that cause? So what do you think happens to the viscosity of the blood as the red blood cells count starts to go up? It can start to sludge. It's going to start to go from, say, flowing like water to flowing something like honey or maybe even molasses in some cases. And what do you think problems that can cause? The blood doesn't flow, it's going to what? It's going to start to clot up, and it's going to start to prevent flow of oxygen-rich blood to different tissues, like, say, for instance, the brain. Not great. Or, say, for instance, like the heart. Also not good. We need to keep oxygen flowing, and blood needs to be of appropriate, you need to have good flow, right? As we talk about the rheologic properties of blood, you need to make sure that it flows appropriately. So, in some cases, anyone familiar with the term blood doping? What is blood doping?
Giving themselves like blood transfusions, right?
Yeah, so giving yourself blood transfusions. So, for instance, you think like really high-profile athletes who've been, say, like banned from their sports for blood doping. They were usually taking out, an amount of their own blood, storing it, and then, while their red blood cells were starting to reproduce themselves on their own, then right before the event, they would then, infuse that blood back into themselves. So they say, oh, great, now my hemoglobin's a lot higher. Have a lot more hemoglobin available to deliver oxygen to the tissues. I'm going to be that much more able to, perform in my given sport, right? But the problem was some of those patients ended up stroking out because the blood was so thick at that point. And again, when you're exercising vigorously, what do you think happens to your fluid status? You tend to become more dehydrated more than anything, right? And again, if you're not especially hydrating adequately. So the blood was getting more concentrated. And the blood was also thicker because of all those extra red blood cells. Blood flow to the brain stopped at some point, and then they have a stroke. Not great, right? That's one issue. And another way you could potentially do blood doping is if you were to actually give yourself erythropoietin, right? So for patients who have chronic anemia, their chronic illnesses, they think like a lot of like kidney patients, because we mentioned erythropoietin is developed where? In the kidneys, right? So there's a long-term kidney patient, chronic kidney disease. They oftentimes develop anemia, either due to blood loss due to like lab testing or dialysis, or just the fact they don't have a lot of erythropoietin around. What's interesting with that is that we have certain guidelines. We know that we want to make sure they get their hemoglobin to a right concentration. If we continue giving them EPO, that's a short way of saying erythropoietin. If we continue giving them that beyond that level, their hemoglobin gets too high. Guess what? Same thing can happen. There's been thromboembolic events where the patients have stroked out or have had a heart attack secondary to that. So again, it's one of those things where you don't want to have too much red blood cells around because again, that causes the viscosity of the blood to increase, and that's not a good thing, right? We want the blood to flow as it should. Okay, so some other things, and why do I put this picture of this very elevated area? Yeah, so the higher up you go, you're going to find there's less oxygen, the partial pressure of oxygen tends to decrease, and so why might that affect red blood cell production? And so the body's detecting there's less oxygen getting into the system, right? So it can overcome that by actually increasing red blood cell production. That's why you might see like sports teams and things like that going up to places of high altitude in order to exercise there, to train there, in order to try to increase their own EPO production, and then go and have their sports wherever they perform them.
Is that a big difference between that and blood doping?
It is a legal way. There's nothing saying like where you can train or can't train, right? I remember we had a conference I went to one time in Denver, Colorado, which Denver is also called the Mile High City, and our elevation here is what? We're probably actually below zero in some cases, right? We live in a swamp. And so, going from here up to Denver, I was not prepared for that sort of altitude difference there. So, ended up like walking up just a single flight of stairs. I had never been so winded in my entire life. It was incredible. Just because there's a lot less oxygen that my hemoglobin levels that are used to kind of a zero level altitude, we're used to dealing with. And so, after a few days or so, you can maybe start to see that improve, or people that live there for a long time, that happens naturally. But in the meantime, you're going to be very fatigued, even doing, very limited amount of physical activity. So that's why escalators were so important there, just to get around, so I wasn't like huffing and puffing everywhere. Yes, sir.
Is there any like benefits to like oxygen bars? Like we kind of I've seen like a lot of.
I don't know. I think having not that I ever participated in an oxygen bar, I don't know necessarily if there's any clinical benefits there. I'm sure the alcohol you're imbibing with the oxygen, maybe. Is that where you do oxygen bars? What? I guess I don't. One time I saw an oxygen bar that was inside an actual bar. I don't know if that was actually beneficial. Anyway, I don't know. I have no idea the clinical benefits of actually going to an oxygen bar. But one thing I do see sometimes is you may see this guy has this little training mask on, and this actually will impair the amount of oxygen he can actually inhale. And so what's really funny though is that you may see these guys that are exercising in the gym and they're like going crazy and they're sweating buckets because they have less oxygen actually getting delivered to the tissues. The problem is what happens when they take that mask off? they're back to breathing normal partial pressure of oxygen here. So again, you need to have kind of a constant sort of deprivation of oxygen in order to stimulate that EPO. So as soon as they take that mask off, they kind of lose that stimulus. So if they wore it 24/7, yeah, it would probably have some effect on their hemoglobin over time, but if they're only wearing an hour in the gym, probably not going to see a big difference there in the long run. I think someone else, you had a question?
I was going to say, like with the oxygen bars, not necessarily that, but with burn victims or any kind of trauma, they put them in hyperbaric chambers to increase it when they actually do the opposite. They increase your oxygen load and speeds up healing.
Yeah, absolutely. So hyperbaric chambers are kind of interesting. Anyone ever seen like what a hyperbaric chamber looks like? Not fun. They look like big, like soda cans essentially. So there's different types. There's multi-place and single place. The single place are really scary because they're like acrylic coffins essentially. They like slide you into, and it's bad. But basically, they try to increase the pressure that you're under. So it's almost like diving down, like really far underwater. And so by increasing that pressure, by getting that oxygen much more concentrated, it seems to help with wound healing pretty significantly. So that's one of the main businesses they do that for. We do it a lot of times for carbon monoxide poisoning from a tox standpoint. So we'll do that occasionally. Yeah, for the bends, yeah. So people have like diving injuries where they're coming up from high pressures up to the surface, and that air that is dissolved in the blood starts to expand out. That is another thing we use hyperbaric chambers for. But you had a question in the back.
Does that change the tolerance pressure significantly when you compare someone who lives at a higher altitude versus someone who lives in low?
Did I compare?
The osmotic pressure in the blood.
I don't know, because like the red blood cells themselves, I don't know how much osmotic pressure they account for versus other elements like the albumin and things like that. So not that I know of. I don't know any specific differences there. You had a question?
Yeah. So how long does it take, like, to deprive yourself of optimal oxygen until you start seeing a difference?
It would probably take a few days to weeks before you really see kind of full acclimation there, before you see like really all that difference there. Because again, like it's a hormone, it's not going to work instantaneously. Like it has to generate the EPO, right? The kidneys have to detect that limited oxygen supply, will then develop the EPO, and then it has to get sent to the blood or to the bones in order to develop the new red blood cells. So it takes time, probably at least say a few days before you really start to see any significant changes there. Any other question?
I was just going to say, in sort of response to her question, they've actually found in South America there's been isolated tribes that will live up on high elevations, and when they compare their blood to our blood with hemoglobin, they actually have a different form of hemoglobin, which binds at a higher binding capacity with the oxygen. So it doesn't necessarily change pressure, but they have a better binding capacity.
There you go.
It's just developed over centuries.
Yeah. So there you go, a little bit of evolutionary change there. Yeah, and so we'll talk about like fetal hemoglobin a little bit later in regards to sickle cell anemia just a little bit. But yeah, it's an interesting fact there. But anyway, so yeah, so these are the main kind of drivers of developing or of stimulating EPO production. Usually it's going to be things like low blood volume, anemia, low hemoglobin. All these things are kind of depriving the tissues of oxygen that then will stimulate erythropoietin to be developed in the kidney. Again, if you have really poor kidney function, typically you're going to have really poor erythropoietin production as well, and then you're not going to be able to develop those red blood cells. So that's going to be one of the big issues you're going to find with that chronic kidney disease, amongst all the other issues that develop. And anemia tends to be one of the more common ones there. So looking at what we need to actually produce red blood cells, we're going to require several kind of precursor molecules. We're going to need things like vitamin B12, otherwise known as cyanocobalamin. We're going to need things like folic acid. Talk about how those are used in a little bit. And then we need iron. Iron is used for what? That's the heme part of hemoglobin, right? So we're going to need that. It's going to be getting incorporated into that heme pigment there. And then the B12 and the folic acid, those are necessary for making thymidine. So again, remember, don't dump everything from the first test, but remember DNA production. So you need that thymidine there to produce new DNA. Even though red blood cells, do they have a nucleus? They don't, but again, the precursor molecules, those stem cells that are developing red blood cells, those do have nuclei, and those need to be able to produce that DNA to have replication. And again, having deficiency of these molecules can lead to things like megaloblastic anemias, etc. So we'll look at some examples of that as we go forward. Again, how long does the red blood cell stick around for? 120 days, which some people get confused because when you look at something we use to monitor diabetic patients with hemoglobin, anyone know what that is? HbA1c is the glycosylated hemoglobin. That usually gives you a snapshot for what that person's average glucose was for how, anyone know the time period? Usually about 3 months. So people are like, well, wait a second, if we're measuring the red blood cells for this glycosylated hemoglobin and they live 120 days, why is it we only getting like a 3-month snapshot? Actually, I don't know the real difference with that. I think it's just looking at the average basically. And so again, with your red blood cells, you're constantly destroying some and producing new ones. And so you get roughly a 3-month kind of picture with that. So some people have some questions about that. We can talk about it later on if we need to. But again, where are we getting a lot of our B12, our folic acid, and our iron from? Diet, right? So diet's really important here. If you're missing these components, you're going to run into these anemias that can happen again over a long time. Sometimes you're going to find the body has significant stores you can hold on to for a period of time. In some cases, it does not. And so it just depends on the nutrition status of the patient. Okay, so looking at B12 or cyanocobalamin, this is actually kind of interesting. There's a drug we have called hydroxycobalamin. And so what do you kind of notice about this cyan kind of precursor or prefix here on the name here? Does it remind you of any other molecules? Might be like really deadly. Cyanide, yeah. So it's actually, if you mix a cyanide along with hydroxycobalamin, you actually get cyanocobalamin, it's B12. So we actually, if we have someone who's developing a cyanide toxicity, which you may find like in someone like gets stuck in a house fire. House fires is one of those places where you see a lot of cyanide develop. We can actually give them a drug called hydroxycobalamin that will actually bind up the cyanide and then just makes B12. Which is actually kind of really kind of kind of elegant way to deal with like one of these really deadly poison. And then B12, it being, is it fat soluble or water soluble vitamin? It's water soluble, right? So again, water soluble vitamins, you have too much of them, what happens to them? You just pee them right out, right? So it's kind of like, they get a little extra energy boost because they got some B12 going on, but yeah, it's a lot better than being cyanide toxic, but I digress. B12, again, coming into our diet, it requires what we call intrinsic factor. This is going to be developed actually within these parietal cells within the stomach. So actually you can have issues where patients are maybe missing part of their stomach. Maybe they had a resection done at some point due to GI disease. You may find they actually do not develop enough intrinsic factor and they would have poor ability to absorb B12. That can be an issue there. But basically the B12 is going to bind up to the intrinsic factor that then can be absorbed through pinocytosis. Remember that? It's that cell drinking sort of thing that happens there. And if you have the case where you do not have enough intrinsic factor, you actually develop what we call pernicious anemia, right? So you're missing those precursors. We can't actually develop those red blood cells because you can't produce that DNA with missing the thymidine there. Hemoglobin itself, again, you're going to find that the synthesis will start very early on in the pro-erythroblast sort of state, and it will continue on into the reticulocyte stage, right, when it's in the kind of immature form there. Notice here it's kind of 4 heme molecules all attached together. So we got 2 alpha and 2 beta chains there, and then you notice you're going to have a heme group here. This is where the iron actually gets involved, and that's able to bind to oxygen, right? So again, how many molecules of oxygen can hemoglobin bind to? 4, right? So again, the more hemoglobin you have around, the more ability you have to bind up to oxygen, the better you can deliver that tissue, that oxygen to the tissues there. Now, how do we form hemoglobin? This is coming, we get succinyl-CoA, which is actually coming from the Krebs cycle, and then we're going to mix that with the glycine and get a product called pyrrole. And then 4 pyrroles are going to combine together and make this protoporphyrin 9. And then once you add that with iron, that gets that heme molecule. So that's actually a heme pigment. And then once you combine that with the polypeptide chain, 4 chains come together, and now you have hemoglobin, right? And again, if you screw up any of the steps having been before this, you may have an impaired ability to produce hemoglobin. Obviously, if you don't have any iron around, guess what? You're not going to be producing any hemoglobin either. That's really an important thing to consider. So anytime you have a patient with anemia, the first thing you're going to be checking for is what? The iron status, right? And anytime you're giving patients erythropoietin, you need to make sure you're also giving them what? Iron, right? Because again, iron is a very easy step to miss, and again, if they're not absorbing it appropriately, they don't have good enough stores, they're not going to be able to produce hemoglobin. It doesn't matter how much EPO they're developing on their own, it's never going to increase hemoglobin production. Now, with the chain alterations I mentioned, like sickle cell anemia, you can find here if you were to substitute a glutamic acid for valine for glutamic acid, it actually can cause in these low oxygen states for these crystals to form, and the red blood cells then form that kind of sickle shape to them. And you notice here what happens to the flow. It becomes a lot more viscous, right? So again, you're impeding blood flow in these sickle cell patients, and so they usually come up with called veno-occlusive disease, where basically the blood flow is not occurring appropriately. And you know any like anything that can like any manifestations of sickle cell anemia? Yes, you have clotting that occur, a lot of pain, usually chest pain, because again, you're kind of impairing blood flow going around, especially with the heart. Strokes can happen. You can also have priapism. Anyone know what priapism is? So there's a really painful erection that occurs because again, you're stopping blood flow heading to the penis. So lots of different issues that can happen from that. And actually, one of the first things you'll do with a sickle cell patient is give them what? Because you say low O2 causes them this conformation to occur. What do you give them? Hook them up with oxygen, you put them on a non-rebreather, give them 100% O2, and that's going to help to prevent any further red blood cells from getting that sickle cell conformation. Yes, ma'am?
Oh, no. Sorry.
No question? Okay. Oh, gotcha. Yeah, so that's one of the big things. So we see a ton of sickle cell patients that come into our ER because, again, a lot of kids get affected by this. And one of the first things you have to do is like manage give them oxygen, and then also they have a lot of pain issues. So again, they're very frequent users of opioids. We see them very frequent in the ER when they come in for these pain crises. They're also more likely to develop spleen issues. And one of the things you'll realize the spleen is really important for helping with immunity. And if you have a functional sort of asplenia, the spleen's not working very well, you have to worry about infection as well. So if you have these sickle cell kids who come in with fever, you automatically have to assume they have an infection. They oftentimes get a lot of antibiotics as well. Okay, so these kids are very complicated to work up medically, and we see them very, very frequently. A lot of transfusions they get as well. Okay, so again, looking at total iron, total body iron levels. So again, 4 to 5 grams or so, about 65% of that should be found in the hemoglobin. Does anyone know the name for this molecule? It's actually a Ferris wheel. Nah. Anyway, right, so basically the way we're going to be absorbing this is with apotransferrin. This actually gets secreted into the bile, so it comes out of the biliary tract and is going to combine with the iron to form transferrin. Transferrin itself can then be absorbed through pinocytosis through the GI tract, and then it gets released as plasma transferrin. Okay, so again, when it makes apotransferrin plus iron, then you're going to get that plasma transferrin. At that point, once it is going to, if it has extra iron, then you can need to store it. That's where iron's going to form this apoferritin, and that's where you're going to get ferritin. This is your main form of storage iron. Okay, so again, if I took a patient's blood and I was measuring ferritin levels and it was very low, that would tell you what? They don't have much stored up. I'm using a lot of it probably to produce things like hemoglobin, right? The problem with iron is that we don't have a good way to eliminate it through, say, like the kidneys or anything. The main way we're going to regulate it is by how much we're actually absorbing within the GI tract. You're going to find that, we eliminate it mostly through the feces, usually by having things like macrophages degrade the hemoglobin, especially when red blood cells are being eliminated, especially in the spleen. That's where you get rid of a lot of your red blood cells. You'll have macrophages there that will help to chew up the hemoglobin, will free up the iron, and then some of it can be excreted in the bilirubin, where we'll go out with the feces. So we have a hard time getting rid of excess iron, but we can regulate how much we absorb fairly well by using things like that apotransferrin. Okay. So again, iron is very, very important. Make sure we have that in good supply, otherwise we cannot produce a good amount of hemoglobin. Okay. So you notice here that iron there is in the 2+ state. Anyone know what happens if you were to oxidize that and turn it to the 3+ state? You guys already know methemoglobinemia? That's fantastic. Good job. Yeah. So basically, if you have, we see this sometimes with strong oxidizers. We see this sometimes with certain drugs, or patients have like an enzyme deficiency. That'll turn to the 3+ state, and then that hemoglobin will turn into methemoglobin. And know what it likes to bind to? Actually, it likes to bind to water rather than oxygen, and that actually changes the color of it. Because again, you think blood, you think what color? Think kind of red, right? And that's what gives us a little bit of a pinkish hue, is that red blood circulating in our bloodstream. If you have enough of that turning over into methemoglobin, it's binding up water, it actually turns blue. And so if you ever see a patient who looks blue, for one, you want to rule out that they're not like cyanotic, or you make sure they actually are breathing appropriately. But if they are, otherwise looking okay, and they're blue, you should think methemoglobinemia, because that can be pretty easily fixed. We have a good antidote for that, but that's something you may run into occasionally. And the other thing, if you ever hear a nurse who draws the blood and it says it looks like chocolate, chocolate brown blood, that's usually a sign of methemoglobin as well. So that could be one of those things you see that and you're like, oh, that's kind of interesting, wonder what's going on. Chances are it's related back to that methemoglobinemia. So. Okay, just some ideas of different foods that might be high in B12, iron-rich foods, iron, and things like that. So again, anytime you're having patients who are going on any kind of like specialized diets or anything, you want to make sure they're at least aware, make sure they're, if they need to take a multivitamin that has some, extra of these molecules, make sure they're getting that. Otherwise, it can run into some deficiencies in the long run. It can be problematic. Okay, so moving on, next we have the formed with. So again, looking more specifically at the red blood cells themselves, notice these are nice flattened biconcave sort of discs here, and you're going to notice that the main function there, as we said, is to transport hemoglobin around. Normal hemoglobin or so is around 15 grams per deciliter for men, 14 for women. And when I was talking about earlier those chronic kidney disease patients and worrying about their hemoglobin sludging up the blood too much, we actually will only shoot for like 13 for those patients. So again, we shoot for kind of low normal for them in those cases, because we know the viscosity is such a big issue. And the hematocrit, which is what?
Percentage of red blood cells.
Yeah, basically that if you were to take all the whole the sample of blood and you were to spin it down, basically that percentage there of red blood cells, the hematocrit, usually 40 to 45% or so, right? Now the other, we talked about this enzyme system before. We talked about carbonic anhydrase. This is really important for maintaining the buffer system. I think Dr. Butler said you guys are covering acid-base disorders in the upcoming lecture, so I feel very bad for your Friday afternoon having to listen to me and then acid-base disorders. not great. But that'll be really important for that. We'll talk about this much more when we get to the pulmonary section, because again, regulating how we're picking up CO2 from the tissues and delivering it to the lungs, and then picking up O2 and then delivering that to the tissues is very, very important to understand how that works. Just remember, though, for our purposes here, that carbonic anhydrase is able to convert CO2 and water over into carbonic acid, and then I can break it down into bicarbonate and that H+, right? Again, this is how we're going to buff our system. And again, if you are monkeying around with carbonic anhydrase, you can run into issues where it become very acidotic, not good for you, right? So anyway, note also red blood cells lack nuclei, they have no mitochondria, and roughly a 128 lifespan. When you're done with the red blood cells, then you're going to be getting rid of those in the spleen, and then the hemoglobin gets metabolized by those macrophages, right? And then we can either eliminate that out through the biliary tract, the extra iron, whatever happens to be, then some of that can then eventually be recycled. Next we have our leukocytes, or white blood cells. So again, these do have nuclei. They do have mitochondria, so they're fully functional sort of cells as opposed to red blood cells. They typically move in sort of like an amoeboid sort of fashion there. And so you can kind of divvy these up into the granulocytes and the agranulocytes, or granular and agranular sort of white blood cells. I don't know if this ever helps you guys. I remember when I had to learn this in school, we always learned never let monkeys eat bananas. That's our way to remember that. And so I just remember this as never eat bananas as my granulocytes, and then little monkeys for my agranulocytes. If it helps you, it helps you. If not, then you can come up there and mnemonic there. But again, each of these cells are going to have their own specific function, as we'll talk about here in just a little bit later. All right, typically the granular leukocytes are going to be living around 4 to 8 hours or so once they get secreted out into the blood, and then when they travel into the tissues themselves, can last a little bit longer, usually 4 to 5 days or so. Now, what are neutrophils good for? Phagocytosis are usually some of the quicker molecules on the scene, the cells on the scene, in order to deal with things like bacteria and viruses and things like that. Now, when you're looking at your CBC, you know, when you're looking at the differential, what do you notice is kind of the most prominent sort of cell there? Usually the neutrophils, right? And that's also what you're going to be looking at if you're wondering if the patient has an active infection or not. Because what do you expect to see if the patient had an infection? You should see an increased number of your neutrophils, because again, that will be showing you that, hey, there's some trigger here that's making your neutrophil count go up and probably to deal with some sort of bacteria or virus. And so anyone know what you call that? Call that a left shift. You ever see a left shift? That's usually going to be an increase in the number of neutrophils that are there in order to deal with infection. So sometimes you'll see that. So you'll see like a total increase in the white blood cell count, and then we see a left shift. That usually means an increase in the neutrophils that are available there. So it could be indicative of some sort of like bacterial infection or some other infection you're dealing with there. Those are important. This is also a big thing because we mentioned that these cells, do you think they're constantly replicating or hardly ever replicating? The white blood cells? Usually most of the blood cells, red and otherwise, are going to be replicating pretty frequently, right? Because again, we're going to be cycling these out fairly quickly. And so one of the things you'll see when you're dealing with things like cancer, things that we're trying to give chemotherapy and things like that, these are some of the first cells that actually get hit. And so when you have the loss of things like neutrophils, what do you think happens to your patient in terms of like infection? Much higher risk, right? So again, anytime you have a patient who's, say, who's neutropenic, whether due to cancer, whether due to HIV, whether due to whatever kind of disease state, this is going to be an issue where you're much more likely to develop infections. Things like tuberculosis are more likely, viruses are more likely, even funguses or fungi, I guess, are more likely to occur. So you'll be really careful when you have those patients who are immunodeficient, especially if they're missing their neutrophils there. Basophils are good for releasing the anticoagulant heparin. This will come up again a little bit later when we talk about the clotting cascade, but heparin is very important as an anticoagulant. Good to remember that, bless you. And then usually helping to increase inflammation. So it's going to release things like histamine, things like serotonin. These become very important when we talk about inflammation a little bit later on. Anyone know what histamine does for us? Yeah, allergic reactions, what does that cause? Inflammation, but what is kind of indicative of inflammation? Like swelling, you can see vasodilation that occurs there, you're going to see itching, things like that. So again, this is good to understand kind of what histamine is doing as far as allergic reactions go, or just whenever histamine is being released, because again, you'll see this is a big deal with like certain drugs we're using to block that. You'll see it comes up all kinds of spaces for inflammation later on, as we'll see later. Serotonin will be another big one as well. It also helps to intensify that inflammation, right? Again, normally you think serotonin is being sort of a neurotransmitter up in the CNS. You think about that being used like depression and whatnot, but it does come up here in the bloodstream when dealing with inflammation. Especially when you get the clotting cascade, we'll see it come up again. Okay, eosinophils. Anyone know what these are good for? Yeah, usually for parasites, it's going to be good for finding out. So if you were to see, for instance, if you look at the CBC with differential and you see an increase in this eosinophils, you would think probably a parasitic sort of infection, right? Because again, the body knows what it wants to fight off based on, as we'll see, the immune system later on, but it'll be able to upregulate those cells in order to help combat that particular type of infection. You can also see that it helps to release certain, you'll see this in conjunction with asthma quite frequently. This actually helps to combat histamine, has some mediators that can help to limit the effects of histamine, which is good, and will also help with phagocytosis of whenever antigens are binding to an antibody complex, like say like on a parasite, it'll help with that, the phagocytosis of that. Okay, and then on the agranular side, we have the monocytes. These are good because they turn into what? Macrophages, absolutely. Macrophages are good for what? Yeah, another good phagocytosis, phagocytic sort of cell, good for like a Pac-Man sort of effect, right? And then lymphocytes is going to be really important for like antibody generation, being able to identify foreign cells versus host cells, things like that. So it's going to be really important for immune responses. We'll see later on. And again, you can kind of break those down like your T cells, your B cells, natural killer cells, all that. This will be very, very important when you're looking at that. Okay, and there are platelets. These are coming from what kind of progenitor cell? Yeah, usually the megakaryocytes are going to be breaking down, and then you have your thrombocytes there, your platelets. Again, these are lacking the nuclei. These are going to have the shortest sort of half-life, or shortest lifespan of all the cells, so about 5 to 9 days or so, as compared to like your red blood cells. We mentioned are going to be around for a lot longer than that. These are really important for helping us with clots. These are usually going to be the first sort of cells that are going to be starting to form that clot. So when we look at this a little bit later, you'll see these are the first things activated to sort of form a nice platelet plug, and that's going to trigger off the clotting cascade. Several factors there, but you'll see that the fibrin will then get involved with the platelets as well. Okay. These also release serotonin, which again is going to be good for vasoconstriction. We'll talk about why that is good in a few minutes. And again, you can look back at the slide. You probably don't need to know the description necessarily or the specific numbers, but just have a, you'll get a feel for these when you're looking at like a lot of CBCs with differentials. You'll get an idea of kind of what the average numbers are. Or for most people, you'll see like if someone has a disease state, they have an infection, you'll see those changes that occur. So you get a feel for that. I'm not going to ask you anything specific as far as what a normal value would be. However, I might say something like, hey, you have eosinophils that are going to, you have a CBC with differential for a patient. Eosinophils are this percentage. Here's the normal. What do you think that could mean? How like, virus, I'll say like bacterial infection, or I'll say like parasite. You would say parasite, right? So things like that. So kind of know what the cells are kind of good for. And if you were to see an increased value or decreased value, what that might mean, kind of the downstream effects of that, right? Or if I would say, you have a lack of neutrophils, here's the value you get from the CBC. Here's the normal. What do you think that might mean for a patient's ability to fight off infection with a bacterial infection? You'd say it would be lessened, obviously, because you have less neutrophils around to phagocytize those bacteria. Okay, I think we're almost at the hour. Yeah, let's go ahead and do a 10-minute break. We'll come back and then continue on to more about blood. All right, so any questions from the first half? I believe I misspoke probably both ways, but if you look back at the slide, we're talking about sickle cell very quickly. It says valine substituted for glutamic acid in that in the hemoglobin chain. So glutamic acid was originally there. Valine got substituted for that in people with sickle cell. Okay, so I just wanted to make sure I clarify that and was clear on that. Anywho, I also told that person that would likely not be on the test. I can almost guarantee you that particular question would not be on the test, especially now that I told you guys that. So anywho. So moving on, talking about red blood cell antigens and blood typing. So you're sure you guys have heard of blood typing before, right? So anyone know what their blood type is off the top of their head? All right, so are you positive? It's a valid question to ask. Okay, anyway. Right, so basically we're going to see that our red blood cells have the ability to produce different antigens, essentially, right? And this helps our body to identify whether it's our own blood, it's kind of a host sort of cell that's been produced in our body, or potentially if you were to infuse someone else's blood, is that something that the white blood cells should try to attack and get rid of? And so that's why it's really important whenever you are getting someone ready to receive blood, what do you need to do to them beforehand? You need to do a type and screen, right? At the very least, you do type and screen to try to figure out what blood type they have. You're screening them for some of these different antigens. And then in some cases, you'll do what they call type and cross, which is actually where you're actually reserving the blood for that patient, essentially. We're actually doing the final step. So that way, when you do a type and cross match, you will determine that patient is good to receive that blood, and then it'll be administered to them, right? So type and screen is only kind of doing the initial testing, and then type and cross match is where you're actually getting the blood ready, or sample ready to be able to give into that patient. So anyway, but in some cases, do you always have time to do that for a patient? Some cases you don't, especially trauma. So you may actually find some cases where you need to have blood that's ready to go. They can be given to anybody. We'll talk about what that is in just a second here. So we'll talk about universal donors and receivers, etc. But anyway, so again, there are a couple different main blood types. Anyone know what the different types are? A, B. I was hoping no one said C. I was really worried someone said C. Not a blood type. Yeah, so the A, B, and then there's O, right? So again, this all goes back to what type of antigens they're actually producing on the surface of the red blood cells. So type A is having what sort of antigen? They have the A antigen, right? B has a B antigen. Type AB has, they have A and B, and then type O has neither, right? So again, they're going to have either of those antigens there. That's important because when you're looking at the antibodies in the plasma that are available to interact, and we'll talk about the complement system, we'll talk about antibodies and antigens reacting and whatnot later on, but basically someone who has type A blood, they have this antigen here present on the red blood cell, they are going to be producing antibodies against type B. So what would happen if I were to inject that person with B type blood? Those antibodies would go and they'd bind up to it, and then that would target the immune system, come along and to get rid of it, right? So again, you could have something like a hemolysis where basically we're lysing those red blood cells because they've been targeted by the immune system as being, hey, this is foreign, we don't like this stuff, right? Now, people have B type blood, have the B antigen, they're going to be producing A type antibodies, right? So similarly, you don't want to give them A type blood. People have AB antigens, they're not going to have any antibodies, right? So they're going to be a lot safer to receive any type of blood for the most part because they don't really develop any of those antibodies there, okay? This is one component of this. And then if you have type O blood, they're going to be developing, because they have neither antigen, they have antibodies for both A and B, which means they tend to be pretty persnickety in what type of blood they can receive, okay? Not the patient's choice, but anywho, so you can type A, type B, AB, and O. So good to know what type of antigens they have there, so that way you know what kind of blood they can receive. Okay. So again, as I mentioned, the antibody production here usually will be producing the opposite type. So if you have A, you're going to be developing B antibodies unless you have AB, and then you're going to have neither. If you have type O, you're going to have both in those cases. So in that case, when we're talking about something like a universal recipient, that's going to be type AB, right? Because they don't have any antibodies. So someone who's AB, could they receive O? Absolutely, because that has no antigens on there, right? Could they receive A? Yes, they could receive A, even though that has antigens on it. They don't have any antibodies to react with it, right? Could they receive B? Yep, and can they receive AB? Right, so since they are have the ability to get any type of blood, they're a universal recipient essentially. Versus on the other hand, with type O, because they develop A and B antibodies, what type of blood can they get? They can only get O, and that's it, right? So again, that's why you're going to find those patients are going to be, it's more difficult to find that type of blood because again, it's going to be, they can only get that one type versus their AB. So again, transfusion reaction would happen if they got the wrong type of blood, and that way their antibodies would start to attack those foreign blood cells and cause that agglutination to occur and then cause eventual cell lysis, right? So again, all the hemoglobin spilling out is not going to be really effective for that patient at that point. Okay, you kind of see that picture here where the antibodies are attaching to the red blood cells and they just kind of lyse apart, right? No good for a patient. There's also, we talk about, you know, say A positive or A negative blood. What's that referring to? Rhesus monkeys. And you're just calling your patients monkeys? Some of them may act like, especially in the PDR, we have some kids that are just like bouncing off the walls. But this is referring to this D antigen that's going to be present on some blood, right? So again, in addition to being O positive or being O or A or B or AB, you can be O positive, O negative, A negative, A positive, etc. And so that's going to be a particular antigen that can be expressed on those cells as well. You can see here like AB positive, they're going to have basically every antigen present there on the cell there. And there are other antigens that are present, but these are the main ones we're going to talk about, whether A or B, or talking about the D antigen as well. So basically, if you're Rh positive, it means you have the D antigen there. If you're Rh negative, it means you do not have the antigen. But as opposed to looking at like A and B typing of blood, they actually, baseline, they don't produce any antibodies against that D antigen, okay? So that's kind of the difference there. But however, if you were to inject, say, Rh positive blood into that patient, could they develop antibodies against it? Yes, they will eventually, right? So that's why it becomes really important for pregnant women that we be able to neutralize positive blood. So for instance, if I have a mother who is going to be Rh negative, and then the dad happens to be Rh positive, that baby could be either negative or positive, right? In those cases where you may find that the baby is positive, if some of those red blood cells get into the maternal blood flow, that mom can then develop some antibodies against that. Okay, so again, mom's negative, she's starting to develop antibodies against that D antigen. At that point, she develops antibodies. Again, this usually doesn't affect the first baby, usually when you have repeated pregnancies. But then some of those antibodies can then cross the placenta and then interact with the fetus. And so what do you think happens to a fetus that has all their red blood cells starting to get attacked by these antibodies? It's not good for them, right? So in some cases, you see miscarriage, you see stillbirths related to this. something they call trying to find it, I put it on here, but it's erythroblastosis fetalis, where basically you're having all those red blood cells in the fetus actually being affected by mom's antigens, antibodies essentially, right? So we actually have a drug that we give. It's called Rogam. Anyone ever heard of Rogam before? Yeah, so it's a very frequent drug we give to pregnant women, especially a few weeks before, as they're getting ready to, you know, kind of towards the end of pregnancy. Anyone know like a normal pregnancy duration is? Yeah, like 38 to 40 weeks or so. So usually like around 28 weeks or so, we start to consider giving Rogam to those patients, especially on like subsequent pregnancies. But so for instance, like in my wife, she's Rh negative. I happen to be Rh positive. So for both of our pregnancies, she ended up getting Rogam each time, right? Because again, we want to make sure that she didn't develop any antibodies that might attack either one of the fetuses essentially, right? Yes, ma'am.
Is this also called fetal hemolytic?
That would, I believe, yes, that would be another name for the same thing, essentially. Yeah, because again, once those cells start to lyse open from the antibodies binding to them, then that's it, essentially, right? So again, big cause for like stillbirth and miscarriage if it occurs there, right? Does that make sense? So again, you don't want to necessarily, if you have someone who is say O negative, they tend to be the most sort of most difficult to find blood for, because again, they're going to be more likely to develop antibodies against any of those antigens if you were to infuse that into the patient, right? So again, this is another thing we're going to be testing for if you're trying to decide if you want to give someone blood or not. So if in those cases we have like a trauma patient, if someone gets into a car accident, they're losing a ton of blood, come to the trauma bay, they need blood right now. What type of blood do you think we're going to give them? O negative. You want to give them O negative. That means they are least likely to have that reaction. Because again, some of those cases you don't have time to actually test their blood to see what other antigens might be present. If I give them O negative, they're most likely not have any reaction with it. It's the safest one to give. However, it's going to be the one in least supply, because again, is used in those cases very precious when you get that O negative blood. Other ones, if you can cross and screen them, it's going to be much easier to give them something. If they can get AB positive, go for it, right? Which, on the other hand, looking at the universal recipients, who would be kind of considered the ultimate universal recipient? AB positive, right? Because again, they're not going to have any reactions if you give them O negative or anything else for that matter, right? So that makes sense for the Rogam. It's an actual antibody that we've produced that we can actually give to the mom, and so that way it actually binds up any circulating antigen she might have in her body, so that way she does not develop antibodies herself, essentially. So this a class of drugs is called biologics, where it's usually antibodies we've produced. It actually works the same way as like snake antivenom. The same thing, we have antibodies we've isolated that can actually bind up and prevent the mom from actually having a reaction to it. Okay. Okay, any questions on that? All right, yes, sir.
Yeah, you said that Rogam inactivates the antigen level in fetal blood.
Mm-hmm. Yeah, so it's actually it's antibodies. So instead of the mom producing antibodies to attack those D antigens, we actually give the mom some antibodies to actually bind it themselves. So that way she never actually has to produce it at that point, right? So again, they basically kind of neutralizes those cells, so that way the mom doesn't have a chance to interact with it. Essentially, that makes sense. Yeah, so she already has circulating antibodies against that ROD, the antigen that we have given her, and it will neutralize them before she has the ability for her immune system to actually mount a response against it and develop those D antigens. Yep. Okay, let's move on to blood. So basically, hemostasis is going to be what? Yeah, for preventing blood flow from occurring within a vessel. And again, it happens anytime you have a damaged vessel occurring here. And so basically, we're going to have kind of three main stages that occur here. So the first one's going to be vasoconstriction. Why do you think that's good? That vasoconstriction when you have injury done to a vessel. Cuts off, yeah, it tries to prevent further blood flow, right? Try to limit bleeding when you can. We're also going to have formation of the platelet plug. So we're going to see there's some conformations that will happen here. There's lots of different things that will activate these platelets, but they'll interact here and form a platelet plug. And then we'll also have fibrin that will come along and actually form this nice little mesh network. So what it might look like if like Spider-Man was in your blood vessels. But this is going to be a fibrin sort of network here that kind of holds everything into place and then forms a nice clot. Okay. Now, those clots, are they permanent? No, we need to be able to get rid of those as well, right? And so anyone know what we call it when you break down the fibrin? Yeah, I'll talk about fibrinolysis and how we actually get rid of that a little bit later on. Now, the thing here, this will come up, it's good to remember for, especially for farm, because we have a ton of different drugs that are actually going to be interacting with this whole system here. Some of these are actually the same products we actually produce ourselves. When we talk about heparin, that's something our body actually naturally produces, and things we can actually use to actually activate some of these pathways here. So if you ever hear someone getting like TPA if they have a stroke, that's actually something we can actually give to cause that fibrinolysis to happen really quickly. It's called a clot buster, essentially. So this will come up again and again when we get into farm and some other heme categories later on, like in CMS and whatnot. Okay, so typically what you have when you have injury occurring here, now normally these the endothelial cells kind of lining the blood vessels are meant to kind of repel the platelets that are meant to keep them flowing, right? Because we don't want clots to occur where we don't want them, because otherwise you have what? Yeah, thromboembolism. We don't want that to happen, right? We only want the clot when we actually have injury happening here. So what normally happens, once you have damage here, this collagen then becomes exposed. Normally you have the endothelial cells that are blocking that exposure. But if you have injury, then collagen is exposed, not exploded. That'd be bad. You're gonna need a lot of clotting for explosions, but basically the collagen is exposed, and then that will interact with the platelets, and that's usually done through something called von Willebrand factor. Okay, von Willebrand factor is going to be able to bind to and hold on to those platelets there. That is what is forming the initial platelet plug, essentially. Now, what you're going to find is those platelets, once they actually interact with von Willebrand factor, they're then going to be releasing some other mediators that are going to try to recruit more platelets at that point, right? So what are some things that can recruit more platelets? Thromboxane. Thromboxane would be something that actually helps to cause some vasoconstriction. It can also help to cause some platelet activation. Anything else? ADP is going to be a big one. We'll talk about ADP. And there's also some things like kind of cross bridges that actually form. We'll talk about 2B3A a little bit later, so we can get into the farm aspects of things. And actually a really good person to talk to about this would be Professor Gerke, because he actually worked in the cardiology office and did a lot of these caths and things like that, where a lot of these anti-clotting drugs and things like that were used. So he's a good person if you're interested in some of this stuff. But anyway, so some of the things that platelets are going to be releasing include ADP, or just adenosine diphosphate. So again, we know kind of where that comes from. That's going to help make the platelets more sticky. You're going to see that normally platelets kind of share, normally when they're inactivated, kind of a globular sort of shape. However, when they start to get activated, they become much more sticky. They develop these kind of podocytes that are coming off of it, and I'll show you what that looks like in a second. But they become, they change their conformation, become activated, much more likely to kind of grab onto other platelets. Serotonin, again, gets released, and this is useful for causing vasoconstriction and preventing more blood flow from the area that needs to be there. And then thromboxane A2, which is a type of prostaglandin, I'll show you some of these in a minute, are going to cause, again, some more vasoconstriction as well. And again, at this point, you're also going to have the platelets starting to release some factors that are going to kick off the clotting factors as well. So we'll look at this in more detail. You guys are familiar with this already, though. We'll look at it again. So here's a good picture showing this. So imagine inactive platelets. Normally they're just going to be bouncing off the cell walls here, because again the endothelial lining is kind of covering the collagen, so again no exposure there. You also have other things like nitric oxide tends to prevent the platelets from being activated. You have prostacyclin, or PGI2, another name for that. It is also going to be a platelet inhibitor. And then when it gets activated and you have injury occurring, the collagen is exposed. What binds to those platelets initially? It's in the collagen. It's that von Willebrand factor. Remember, so that's going to be important, because then actually you have some patients who are deficient in this, and they are more likely to have bleeding occur, as we'll see in a little bit. But this is going to cause those platelets, and notice how they kind of change shape. They kind of have these arms that kind of stick out of them, and that's going to be useful in helping to bind to other platelets, essentially. ADP is going to be a big one that helps with this. Thromboxane A2 is another big one that helps with this. And then once they kind of form that plug, and they're starting to activate the clotting cascade, we'll talk about intrinsic and extrinsic clotting cascades, then you're going to have fibrin eventually be developed, because we know that at the end of both the intrinsic and extrinsic clotting cascade, the ultimate product we form is what? Well, that's the clot, which is made up of what? Fibrin, right? Fibrin is the main thing we're actually producing there. That will help to cement those platelets into place, and that's going to help us to produce a nice stable clot in that case. Okay. So the prostaglandins are super, super important here, not only dealing with clotting, but also dealing with things like inflammation. So imagine you have your phospholipid bilayer here, right, in just any normal cell. You can have an enzyme called phospholipase C, which will basically help to cleave off a portion of, let's see if I have any viruses. Nope, no viruses, good. We're going to cleave off a portion of the phospholipid bilayer. We're going to get this product called arachidonic acid. Okay, so basically it kind of cleaves off the phosphate group off of that. And so instead of phospholipid, it's just kind of a lipid sort of molecule here. Now there's two enzymatic pathways it can go down. Now again, these will start to come up in other disease states as well as we go forward. But basically, if it were to go down this lipoxygenase pathway, it would then turn into leukotrienes. Anyone heard of leukotrienes before? You know what disease state they're important for? It's actually be important for asthma. Okay, so we're talking about asthma, I mean that's an inflammatory condition, but you're also going to see it causes inflammation and bronchoconstriction, which is what? It's be good when we get to the pulmonary sections, causing constriction of the bronchioles. And what do you think that does to airflow? Yeah, it inhibits it pretty significantly, right? So again, we have that asthma attacks to do that bronchoconstriction that happens there. So we'll see that is going to be important a little bit later. The thing I want to talk about today is going to be the cyclooxygenase pathway. Anyone remember what I said you could abbreviate this to? COX. Remember, so there's going to be COX-1, there's COX-2, different varieties. For our purposes today, just know cyclooxygenase is another thing, another enzyme. They'll interact with this arachidonic acid, and you're going to get several products developed from this. So thromboxane A2, we mentioned this is good for causing platelet aggregation. It's also going to cause some vasoconstriction, so it's going to help to kind of impede more blood flow to the area of injury. We're also going to see that some other ones like PGE2, prostaglandin E2 is going to cause some vasodilation. So some of these have some antagonistic actions. You may see some of them being kind of preferentially formed in the case of bleeding, in some cases more than others. So for instance, thromboxane E2 is good for causing clots to occur. However, prostacyclin tends to have an antiplatelet sort of effect. Okay, so depending on what factors are floating around, whether there's actual tissue injury occurring or not, you may be in a state where you're producing more prostacyclin, or maybe producing more things like thromboxane. Okay, just know these are going to be important as well, because we'll talk about prostaglandin as being useful during pregnancies, because it actually helps to induce labor, things like that. So these will come up again and again.
What did you say regarding phospholipase C again?
Yeah, that's basically the enzyme that's going to cleave off that phosphate group and is going to form arachidonic acid. Okay, so that's not included on here. I probably wouldn't ask you a test question specifically about phospholipase, but I would know the difference between like the cyclooxygenase pathway versus the lipoxygenase pathway. Because when we talk to POEM, I'll talk about POEM, which will be on this test. That'll be important there as well. Okay. Anyone remember the class of drugs we talked about that actually interact with the cyclooxygenase? Yeah, so we talk about NSAIDs, we talk about things like ibuprofen, aspirin, naproxen. This will come up again. These will be COX inhibitors essentially, so kind of keep that in the back of your mind. Okay, so let's say we have our clotting cascade here. So again, the main thing we're looking for is to get fibrinogen converted over into fibrin. It can happen one of two pathways, either intrinsic or extrinsic, and then they'll eventually meet up to have a common pathway. What's the difference between the extrinsic versus the intrinsic? Basically, it kind of refers to what stimulus is kind of kicking off the cascade, essentially, right? So you're going to find that typically the extrinsic pathway is going to be more, there's actually the vessel wall being damaged. A different clotting factor is going to be kicking off the extrinsic pathway, versus when you have the actual collagen interacting with the platelets, that's what's actually interacting, causing the intrinsic pathway to get kicked off, okay? So do you have cases where, I mean, do these happen, like depending on the injury, either have one or the other? No, typically they're both happening in concert, right? Because again, this is an example of what? What kind of feedback loop? This is, yeah, it's still a case of a positive feedback loop, because a lot of these factors, once they're activated, can then feed back and actually cause more clotting factors to be activated. Because again, this is something where when you have bleeding, you want to stop it real quick, and that positive feedback loop can be useful to have that occur, right? Now again, you don't want that to happen unchecked, because if I kick that off in one injured vessel, and then it kept clotting off everywhere, then that would be no good. I'd no blood flow anywhere. That's not what we want. So there's certainly some anticoagulants that are going to be important to work with this system, but just know this is an example of that positive feedback loop. So we'll get into the details on the specific ones here, but the main thing we're doing is we're activating that thrombin, and that's going to help to convert fibrinogen over to fibrin. Okay, that's the main thing we're looking for, because that's going to help to cement in those platelets and to form that good stable clot. So another picture showing the different clotting cascades here. So again, the extrinsic pathway is on the left here, intrinsic on the right. Just know extrinsic is going to be more activated when you actually have like vessel wall damage actually occurring here, because this is where tissue factors are going to be important, versus the intrinsic pathway is going to be more that collagen affecting the platelets there. Okay. But they're all going to meet up in the common pathway. That's not going to change. We'll look at some cases where we can actually affect the system pretty dramatically, either with like medications or other things. Okay, so you can go through this list. I'm probably not going to ask you specifically, like, what is another name for factor 5? I don't really care to know that specifically, right? Because again, we'll talk about them as they become important in the different pathways. You should probably know at least the general sequence of the factors, whether it be intrinsic or extrinsic, kind of know the pathways that happen there. Because again, it's good to know that if I interrupt, say, production of, say, factor 8, what does that do to the system? How does that affect the system? Or if I say, for instance, I have a factor 9 deficiency, what does that actually do for me? Anyone know what you call a factor 8 deficiency? Hemophilia, type A or B? A versus factor 9 is what? It's going to be hemophilia B. Christmas disease, right? Less fun disease than what it sounds like. I'm telling you right now. But that's important, because when you have patients who are coming in, you will have patients who come to the ER, because guess what? When often do you think you need to replace these? Like if you have a hemophilic patient. When they have an injury, right? So again, if they're out and you have little kids and they're out there playing football or something, usually they try to tell them not to do high contact sports, but imagine they get an injury, they bump their head. We have to make sure we replace these pretty significantly, because if you find these clotting cascades are going to be thrown off because of a lack of factor, they may bleed. They may have CNS bleeds. They can have bleeds all over the place. It's not good. So again, this is a big thing. You're going to see these kids in the ER with some frequency, and again, as they turn to adults, you'll see them in adult ERs as well. But So first off, we'll look at the extrinsic pathway. Again, this is usually traumatized tissue sort of kicking this off. And it's going to be factor 3 is going to be the thing that is going to be the activator here. So tissue factor, factor 3 gets released. That will then go on and activate factor 7. And again, I really wish that they had just gone, okay, here's factor 1, 2, 3, 4, 5. Like, this is not so easy. The intrinsic pathway is even more confounding than this is, as you'll see. But factor 7, so it goes from tissue factor to factor 7. And then based on different sort of cofactors and other enzymes. Notice here calcium is a big role for this, right? What's actually interesting, I find interesting at least, is imagine you were to take a patient's blood out of their body in order to send it through a machine. So whether it be like a dialysis machine, or for instance, anyone ever heard of ECMO? Or anyone ever like a perfusion machine? That's basically if you have like someone who's undergoing an open heart surgery, this is where basically you're going to funnel their blood out of their system. You put it into a machine that's going to pull off waste products, put in oxygen, and then deliver it back into the patient. We call that extracorporeal membrane oxygenation, or ECMO if you ever hear that. Very, very big for open heart surgery. In fact, we just started doing a bunch of it over at Nemours with our cardiac surgeon team getting started. Anywho, one of the things you have to realize is if you take that blood out of the system, do you want that to clot off in the system? No. And so one of the ways they prevent that from occurring, they actually will give something that binds up calcium. So they'll actually give them a citrate-based anticoagulant. Citrate likes to bind up to calcium, and then that will leave the blood to flow through the machine. And when it goes back into the patient, they'll actually give them more calcium when it enters the system again, and then their blood can then clot. Right? So calcium is a very important factor here. If you're missing calcium, you may be more likely to bleed. Okay, so you don't have to remember anything about ECMO specifically. Just know that calcium is an important factor here that can trigger off some of these steps. Okay, so calcium is a very good signaling molecule. Anywho, so then factor 7, once that gets activated, then that will then go and activate factor 10. Factor 10 is a very, very important one, especially when we're talking about heparin. We're talking about other anticoagulants. Factor 10 is going to be kicking off the common pathway. So that's a good way, or if you were to stop that, then it doesn't matter how much intrinsic or extrinsic cascades are going on. If you stop 10 from working, the system is not going to clot very well, right? And then from 10, it will then go on, and then that will cause prothrombin to turn into thrombin. Anyone know what factor thrombin is? 2. So thrombin, good to know thrombin is factor 2. That will then be activated, and then that can then go on to trigger the conversion from fibrinogen over to fibrin. Okay. Okay, the intrinsic pathway, on the other hand, is going to be when you have that contact of the platelets with collagen. And again, this one's a lot more confusing, but basically you're going to have factor 12 being a factor here. Obviously, you can tell I'm a little weak in my room on numerals, but factor 12 being activated here, that will then go along and in the presence of factor 9, which is that Christmas factor. So that's one that's hemophilia B. If you're missing that, in some cases we'd have to replace that if you were to have an issue. So again, in those patients, they're missing factor 9. Is their whole clotting cascade totally broken? No, you still have the extrinsic pathway that could still work potentially, but you won't get kind of the full effect of it because you're still missing factor 9. Okay, factor 9 gets activated, and then I can go along to eventually activate factor 10, which again kicks off the common pathway there, right? And you notice factor 8 is also going to be involved here in the step from 9 to over to 10. So it's kind of a coenzyme here is going to be working to activate that. That's another one, hemophilia A. We mentioned you can be missing that, and very frequently we have issues where patients would either be missing factor 8 or von Willebrand's factor. So a lot of times when you're replacing that, you just do both at the same time anyway, because those interact with one another very, very strongly. So, as I mentioned, things like calcium, very strong activator of some of these pathways here. Phospholipids can also be useful, especially from the platelets as they get liberated from the phospholipid bilayer. But the main thing is we're going to be in the common pathway activating factor 10, and then we're going to be converting prothrombin, which is factor 2, over to regular activated thrombin. And then at that point, you can have fibrinogen turn over into fibrin. Okay, so fibrinogen being factor 1 essentially in that case. And when it turns into 13, essentially that's when it's really kind of the really strong, stable sort of version of fibrin holding those platelets into place there. So the question is, where do you produce a lot of clotting factors? The liver, yeah, the liver is going to be very important for forming a lot of clotting factors, and in fact, some of them are going to be vitamin K dependent. So if you remember, vitamin K is that water soluble, fat soluble? It's a fat soluble vitamin. Remember, ADEK, right? ADEK is going to be your fat soluble vitamin, the main ones at least. And so you're going to find that is needed in the liver to actually produce several clotting factors. So namely 2, 7, 9, and 10. So say for instance I were to interrupt that process, or say for instance I took out all vitamin K out of the patient's diet, what do you think it might do to their bleeding propensity? Increase it, decrease it? Yeah, they're more likely to bleed in that case, right? Because again, if they cannot produce the factors, so they're missing vitamin K, they can't produce those factors, they can't make they're more likely to bleed in those cases, right? Because you're missing 2, 7, 9, and 10. Because again, factor 7 is involved in which pathway? Extrinsic, good. How about factor 9?
Intrinsic.
It's going to be more than the intrinsic, good. And then how about factor 10 and 2? That's both in the common, right? So again, you're kind of getting, and we'll look at like PTINR and PTT in a second, kind of what they're actually looking at. But this is one of those big places as well where a drug like warfarin is going to work, right? And this used to be like the de facto oral anticoagulant we would put patients on if they had something like AFib, where we were worried about, AFib, they used to have atrial fibrillation. Why do you think it's a problem with? Why do we need an anticoagulant for something like AFib? Yeah, so if you have already kind of like static blood just sitting there kind of quivering and the blood's not moving appropriately, it can sit there and form a clot basically, right? Blood sits around for too long, it'll clot off essentially. And so we would worry about the patients having the clot break off, it would then go out into the systemic circulation, and you worry about it getting up into the brain, causing stroke. And so for patients with AFib, you have to put them on this anticoagulant, warfarin, and that for decades, this is the only drug we had. And in fact, that's where, I mentioned it used to be a rat poison, still used as a rat poison, but we give it to patients, and it's a very good anticoagulant, but lots of issues, right? Namely, what's a big issue you can think about by monkeying with the system? They can bleed and they can die, right? So that's the main problem there, right? But anyway, we'll talk more about that drug later on, but just know that it affects that vitamin K dependent synthesis of your clotting factors. Similarly, if I were to have a very diseased sort of liver, what do you think would happen to the production of these clotting factors? Probably go down as well, right? So that's why I mentioned earlier that sure, if you're looking for liver damage, you could look at ALT, AST, that's fine, well and good. That tells you if those enzymes are being released out into the bloodstream. However, I really wanted to tell if a liver's functioning or not. I'm looking at the PTINR because again, this is going to be affected by the factors 2, 7, 9, and 10. You're going to see those are going to be very much affected there. You're going to find that PTINR is going to rise if you have someone who's not producing these factors, and thus I'm showing the liver's not functioning very well. Right? Does that make sense? If it's not doing its its job to produce clotting factors, probably not doing its job to do much else either for that case. So anyway, so again, those vitamin dependent factors. There's other clotting factors that are produced in the liver as well, but these are the main ones that are going to be vitamin K dependent, as I said. And then anyone know what foods are high in vitamin K? Leafy green vegetables are usually the thing we talk about. Depending on where you're at and what kind of patients you're dealing with, they may have different ideas of vitamin K rich foods or what they might normally deal with. For instance, I did my first rotation was in Palaca, Florida. Anyone familiar with Palaca, Florida? Pretty podunk kind of town. But basically, I was my first rotation was doing the Coumadin clinic there, a warfarin clinic. Where basically I had all these patients who were coming in. I was testing their blood to make sure the INR was correct, and I had to educate them on diet and etc. Because diet is such a huge factor there. And I mean, these are people that are like growing their own like food for the most part, so they eat a ton of kale, ton of collard greens, all these spinach, all these different things. And so you really had to educate them appropriately. Like, okay, well, make sure you get enough vitamin K, but not too much, and just keep it regular, because it affected their warfarin so much. Because again, they had a lot of vitamin K coming in. What do you think that would do to their clotting factors? They probably started to increase in number, right? And so then that would cause the blood to be more likely or less likely to clot. More likely, right? So these AFib patients, you don't want that to happen, okay? On the other hand, if they had not enough vitamin K coming in, what do you think that would do to their clotting factors? Go down, and then their likelihood of bleeding would be increased, right? So again, kind of keep an idea of the relations here, where if I decrease this input, what happens to these clotting factors, and then what does that do for my patient? If they're going to bleed or they're going to clot, right? Those are important to consider because, again, when you're educating, you want to make sure they know, okay, well, why is it they shouldn't get too much vitamin K? Why is it they need to get just the right amount? And so those are good things to know, right? So dietary restrictions, dietary education is super important, as you might be able to tell us, right? Or you had your hand up.
Not me. Yeah.
No.
So if they eat a ton of vitamin K but are still on Coumadin, and it doesn't really matter, right? Because it inhibits.
It does matter, yeah, because you'll find that essentially vitamin K can be utilized itself. So imagine vitamin K gets absorbed into the liver. It can then be used to make some clotting factors, but there's a recycling process that occurs. We like to be able to be a little bit more efficient with our use of vitamin K, so that recycling is what gets inhibited by the warfarin. So, and in fact, when you have someone who comes in, they're bleeding because of warfarin, first drug I'm going to give them is what? Vitamin K. So I can give them vitamin K IV, and that can actually help to replenish that and help the body start producing new clotting factors there, right? So again, that's more of a farm topic, so this is just a tangent, but just know that again, dietary education is super, super important for some of these things because it can have very drastic effects on how well things like drugs are going to work, how well your therapies are going to work for them, right? So looking at some of the anticoagulants, so again, we don't want to kind of clot forever, because then the whole blood or all the veins and vessels are going to be full of just clots. That's no good. We need to keep blood flowing where it should be. And so some of the ways we can help to prevent excessive clotting from happening. So imagine some of the endothelial cell surface factors here are going to be a factor. So things like smooth endothelial surface. When it's nice and smooth, the platelets don't really have anything to grab onto, and so that helps to prevent clotting. They also have this glycocalyx, which will repel some of the clotting factors and platelets. That kind of keeps them from being activated. And then you also have a molecule called thrombomodulin that actually will bind up thrombin. Okay, that's good because again, thrombin's factor 2, right? So factor 2, and this will actually activate protein C, I should say. And protein C is kind of a natural anticoagulant the body produces, as will help to inactivate factors like 5 and 8. Okay, so again, we have natural anticoagulants are floating around to help to prevent clotting from occurring where it should. However, as soon as that vessel is damaged and say something like the collagen is expressed or is exposed, or something like factor 7 or factor 3, I should say, tissue factors available, that's when you're going to start to have that activation occur there. Another big enzyme that's responsible for helping us to prevent clotting is going to be with antithrombin 3. This is actually a molecule that works with heparin to inactivate activated clotting factors, right? So especially things like 2, 9, 10, 11, and 12. We talk about heparin, we talk about anticoagulants in pharm. You'll see this come up again and again there as well. And so essentially what you see here is you have heparin, which our body naturally produces. And you're going to find that it is going to be working with antithrombin 3, and it actually increases the activity of that enzyme. Antithrombin 3 is okay by itself, but when it interacts with heparin, it actually helps to stabilize this conformation here when it binds to thrombin and inactivates it that much quicker, right? So it helps to increase the speed of the enzyme, essentially, to inactivate those factors that much quicker. So it's a very handy molecule. We use it very commonly therapeutically to help prevent patients from clotting off. We use it all the time in the hospital.
Is it a coenzyme or cofactor?
More like a coenzyme, essentially. Yeah. Again, we get bogged down in that terminology necessary. Just know that they work together. They help. The heparin helps make the antithrombin 3 work that much better, essentially. And then obviously you have plasmin. This actually gets converted from plasminogen, and this will actually go and digest the fibrin clots. When I mentioned earlier, when you have a clot buster, we give something called tissue plasminogen activator, a TPA. That's something we produce ourselves as well, but I can give it a recombinant form and give it exogenously to help convert that plasminogen over into plasmin, and then that will go and digest those fibrin and allow that clot to be busted, essentially. So if I had somewhere, like say for instance, the brain was being occluded, a vessel was being occluded by a clot, TPA would be released naturally in some cases to help to break that down, break down that fibrin, and then the blood can then flow essentially again. Okay, make sense? Okay. All right. So moving from clotting into the actual blood vessels themselves, kind of going back into the flow of blood within the body. Obviously, looking at arterial blood really is referring to anything exiting away from the heart. So you think arteries, anything is going away from the heart, which is important because again, normally you think of arteries containing oxygen-rich blood or oxygen-poor blood. Normally think oxygen-rich. Where is that not the case though? The pulmonary arteries, right? So when we talk about the right side of the heart, the pulmonary arteries are what's going to be carrying deoxygenated blood into the lungs. So just don't consider arteries because they're carrying blood away from the heart. So it's an important distinction there. On the other hand, with the venous blood, it's going to be anything carrying blood to the heart. Normally it's carrying deoxygenated or oxygenated blood. Usually deoxygenated, except for the pulmonary veins. They're going to be carrying oxygen-rich blood because they just have left the lungs, coming back into the heart, essentially, okay, to the left side of the heart. And then actually getting to the actual structure of the heart itself. We mentioned we have how many chambers? Only 4, good. And then we're going to have the right atrium. This is typically what we're going to see, and again, this is probably real basic stuff. We'll go into more detail, especially when we get into things like cardiac output, stroke volume, etc. But it's good to have the basics down first before we get into more complicated topics. But right atrium, where's that getting blood from? Superior vena cava. Inferior vena cava is also kind of coming up and dumping into that as well. So I should be receiving what kind of blood? Deoxygenated blood from where? All over the body, right? So again, most of the deoxygenated blood, all is coming into the right atrium there, and then goes from the right atrium to where? The right ventricle, good, and then from the right ventricle to where? It's going through the pulmonary arteries. That will then go to where? The lungs, where it's going to drop off CO2. It's going to pick up O2, and then where? Pulmonary veins. They'll carry it back to left atria, to left ventricle, and then to the body, right? Absolutely. So good. So you guys know the basic flow here. Again, we'll kind of talk about this as it becomes important. Again, if you're impeding flow at any of these sites, you're going to be able to change hemodynamics pretty significantly here. So for instance, if I had something that was impeding flow of blood from the lungs getting back to the heart, you're going to find that there can be some big issues there. So if you have something called pulmonary hypertension, that can be a big problem getting oxygenated blood back to the heart to pump out to the body, right? So we'll see this is also an issue when you have a lot of like venous backflow, patients who have like ascites or liver disease, they have CHF. These are all going to be things that are going to be impeding flow from one area or another. They're going to be affecting hemodynamics quite significantly. So we'll look at some details on that, especially in the next section coming up, I believe. Okay, so we mentioned the pulmonary circulation really is getting blood from the heart to the lungs and then back to the heart. So again, it's be coming from the right side of the heart, from the right ventricles to the lungs, pick up oxygen, drop off CO2, then get back to the left side of the heart, then be pumped out the rest of the body. And then obviously be the flip of that for the systemic circulation. Again, so we're going to see blood coming between the heart to the rest of the body tissues and then go back to the right side essentially, right? And so this is actually kind of interesting because we, you know, I try to use this example a lot of times when I'm talking about illicit drug abuse. So for instance, anyone familiar with the drug cocaine? Not personally, but just familiar with the concept of the drug cocaine. Now, what are some ways you can abuse it? You can snort it, you can inject it, or you can smoke it. What do you call it when you smoke it? Yeah, it's crack cocaine, right? That's me answering that again too quick. But I ask people, like, what do you think is the fastest onset? Which route actually has the fastest onset of action of cocaine? So why do you say smoking? Wouldn't it be injection? And I'm putting it right into the veins. Is crack still different? Crack is whack, I can tell you that much. That's for sure. No, so what actually happens is if I inject something into a peripheral vein, where does it go from that vein? Where's it going to go into? Which side of the heart first? The right side of the heart, and then it has to go where? To the lungs, and it has to go where? To the left side of the heart, and then it goes where? To the brain, right? And then it's going to have all this stimulatory effects, right? However, if I were to say smoke cocaine, which I'm not advocating, very bad for you, that would go from the lungs. It gets absorbed from the lungs there, and then where does it go to? Left side of the heart, and then to the brain, right? So it's get a much more kind of direct sort of flow of inhaling the drug, goes to the lungs, to the heart, to the brain, much faster onset, which also makes it consequently more addictive than you see with other forms of cocaine, right? So again, just a little way that drug abusers can modify the dosage for them in order to get modified to suit their high, essentially, right? Anyway, again, don't do crack, not great. All right, so just another picture kind of showing you how blood's going to be flowing here. Again, we're going to be sending deoxygenated blood up to the lungs where it can pick up O2, drop off CO2, and we'll talk about that in the pulmonary section in more detail, but then come back to the heart and then go out to the circulatory system there. All right. And again, just another table kind of showing you what we've already talked about here. Again, know where the oxygen concentration is going to be low and high versus which kind of circuit it's going to be traveling on, and again, to understand kind of where what the circuit's going to be there, what the flow is going to be, where the oxygen is actually coming in and going out, essentially. Okay, so we also have some valves. What are valves good for?
Backflow.
Yeah, so we're trying to prevent backflow of blood into different chambers. And why is that a good thing? Because we want it to go in one direction, essentially, right? We don't want to be backflowing into previous chambers. We don't backflow into the lungs. We don't backflow anywhere. So these valves are very helpful for that to occur. So the first ones we're going to talk about are going to be the AV valves, or the atrioventricular valves. Obviously, they're located between atria and the ventricles. Perfect, I know. It seems simple, but again, we're going to build on this, so just wait. So again, these are located between the atria and the ventricles. The tricuspid is going to be where? On the right side of the heart, good. So it's going to be separating the right atrium and right ventricle. The mitral, the bicuspid valve on the left side, good. So it's going to be separating the left atrium and left ventricle. Okay. So typically, what you're going to find for these AV valves is that when are these going to be closed? Yeah, when I'm actually doing the actual pumping part. So what do you call that when the ventricles are contracting? Systole, right? So you're going to call that ventricular systole. When you actually have the ventricle closing, that is trying to pump blood where? Let's say just focus on the left ventricle for right now. It's going to try to pump it out to the body, right? So I don't want it to backflow into the left atrium there. So when, you're going to find when I have ventricular systole, that squeeze on the ventricle is going to force the mitral valve closed at that point, right? Now normally it's going to be pretty impervious to flow. However, what happens if I have like some blood trickle through? What do you call that? Yeah, regurgitation. So mitral valve regurgitation, if you hear that, that's basically what we're referring to, is it's improper kind of sealing of that valve there. Good, so that should be the kind of the impetus that closes that valve is when you actually have ventricular systole actually occurs there, right? So again, prevents backflow of blood there. And normally, what do you have to kind of prevent? Because normally you think of the valve, if it had that pressure, the left ventricle pumping, it would just kind of flap that valve backward. You'd evert it. What happens? What prevents that? Yeah, papillary muscles and also that chordae tendineae, right? Those are the things that kind of prevent the bicuspid valve from kind of blowing backwards and keeping that blood flowing back into the ventricle, or into the atria, I should say. Right, so that's important that we have those. Otherwise, you're going to have poor flow, right? The next valves we have are the semilunar valves, and so these are going to be located. There's also going to be an aortic one. There's going to be a pulmonary one, essentially, right? So obviously on the aorta, before the aorta, you're going to have the semilunar valve there. That's going to be what does closing of that valve do for us? So that would prevent blood going from the aorta back into the ventricle, right? So we don't want that to occur. When would that close, do you think? Yeah, so diastole, when you have ventricular diastole, when the ventricle is relaxing, that is going to close that valve, that semilunar valve. So again, the pressure from the blood that's in the aorta is going to push back, essentially, and that's going to close that semilunar valve and then prevent that backflow, and then you can have it flow to the rest of the body, essentially. Okay, so again, this is all meant to have one-way direction of that blood. You don't want anything to backflow more than it needs to. So the aortic valve, again, as I mentioned, is between the left ventricle and the aorta. The pulmonary valve is going to be between the right ventricle and then the pulmonary trunk / artery, right? Now, which one do you think is under higher pressure, do you think? In the aorta or on the lung side? Yeah, the lungs are going to be higher. I'm sorry, the aorta is going to have a higher pressure there, and so that'll be important when we're talking about lung sound, or I'm sorry, heart sounds in just a second here. It's been a long day, long week. This is like my 10th hour of lecture, so I apologize for misspeaking a little bit. But yes, we'll see that this becomes important for heart sounds in just a few minutes here. Okay. Again, just another picture kind of showing you these valves, how they're actually working. So again, when the ventricle, especially the mitral valve, when the ventricle is in systole, when it's squeezing, it's going to close the mitral valve. When it is opening up in diastole, you're going to find that the semilunar valve is going to close at that point, right? This helps to ensure one-way flow of blood. Okay, so looking at the heart sounds, the lub, otherwise known as what? S1, right? So it's our first heart sound. Let's go lub-dub, not dub-lub. Just lub-dub. And this is basically going to be a closing of the AV valve, right? So again, this is closing of either the tricuspid or the bicuspid valve. We'll use both of those together, right? This is going to be occurring during ventricular systole. So when you hear the lub, that's the ventricle squeezing, that's closing the AV valves. Okay, that's what that sound basically is. When you have the squeezing of the ventricle, it's going to close. It's going to cause S1. It's the first heart sound we have there, right? So you can see in this picture here how the AV valves are closed, preventing backflow into the atria. Okay, ventricles are squeezing now. On the dub side, the S2, you're going to find that the SL valves are going to be closed. The semilunar valves are closing at that point. And so again, that's going to be during ventricular diastole. It's when the ventricles are relaxing. They're pulling, essentially, that pressure both from the aorta or coming from the lungs, and also the kind of the relaxation of the ventricle there is going to be sucking in that valve, essentially. And again, we don't want any aversion to happen there, but it's going to suck those closed, essentially. And that's our S2, our second sound. Now, you guys talked about anything about the splitting of S2? So this is something that can occur sometimes. This actually occurs when you have inspiration, right? Not inspiration like do something, but inspiration as far as like your lungs. So when you breathe in, you can actually find there's a splitting of the S2. And basically it's due to the fact that when you breathe in, you're actually lowering intra-abdominal pressure, lowering that pressure there. And so, or I'm sorry, intrathoracic pressure, I should say. You're lowering that pressure, and it actually causes the aortic valve to close just a split second before the pulmonary valve does. And so, when they were to exhale, you'd find that the sounds would kind of be closer together, and you would not be able to hear a little difference there. So sometimes you'll hear that. You can kind of see on this picture here, you hear S1, S2, S1, and when they're breathing in, you'd have like kind of A2, P2. So again, that would be aortic and then pulmonary. And then when they breathe out, you're going to find this kind of will sync back up again. Okay, that makes sense how that happens? So again, that pressure coming from the aorta is going to be higher than it would be, especially on inspiration, than it would be on the pulmonary side. It's going to close that a little bit quicker, essentially. Okay. And then, of course, based on where you're putting your stethoscope, you're going to be able to hear different heart sounds. This will be able to give you a different idea of kind of what's going on with various valves and whatnot. If you have like mitral valve regurgitation, you can put it in certain areas and be able to hear that better than others. And so again, that's why kind of the reason why we were going to place in different spots there. So that's it for the first section of the cardiovascular material. Any questions so far? Right on time, actually. I have a few minutes early, so that's good. Sorry, I'm at the last lecture. You can go home 6 minutes early, but we're going to build on this, right? Next, we're going to talk about kind of how the hemodynamics actually work. We're going to talk about stroke volume and cardiac output, and so things will get a little bit more complicated from there. But it's good to understand the basics here, so that we can go and get more complicated, right? Because again, we're talking about hypertension, we're talking about the kidneys, we're talking about all these different organ systems. It's really good to understand kind of the basics, the fundamentals, so you can kind of build off of that. Okay. Any questions? Nope. All right. Good job on the test, and I'll see you guys next time.